Hello everyone, welcome to MBBS Atlas. In today's video, we'll try to solve some clinical cases regarding anemia. So, reading theory is important, but practicing the clinical based question is also equally important because according to CBME guidelines, the clinical based approach is more from the first year itself. So, in this video, there are totally 7 questions of anemia. We'll try to learn how to approach the question of anemia, how to solve the question of anemia, and please look at the question model. So these models may repeat in the exam. I have tried my level best to almost cover 90% of the model questions which are repeatedly asked in every university basically. So let us start with the first question. A 22-year-old female patient present with generalized weakness, fatigability, and occasional dizziness for last 8 months. Okay. On examination, she has severe pallor, cholionicia, that is the spoon-shaped nails. Her menstrual history reveals heavy bleeding lasting 7 days every month. There is CBC report. The hemoglobin is 7.8 gram per DL. MCV is 65 FL, MCH is 20 picogram, 20 pg. Now, the question is, what is your probable diagnosis? And the second is the physiological basis of the above question. So, what do you think the diagnosis may be? The diagnosis is, first, we'll be looking at the blood indices. MCV, it is decreased, right? MCH is also decreased. So, the morphology of RBC is microcytic hypochromic. Okay, now the morphology of RBC is microcytic hypochromic. Okay, now in the question, the specific symptom which suggests to iron deficiency anemia is cholionicia. So this all the weakness, fatigability, dizziness, pallor are symptom of every kind of anemia, right? So the cholionicia suggests the patient is suffering with iron deficiency anemia. So in iron deficiency anemia, what will the morphology of RBC? It is microcytic hypochromic. So the diagnosis is iron deficiency anemia. Now mention the physiological basis of the above condition. So what do you think why this patient has a iron deficiency anemia? Basically, in the question, they have given the menstrual history of the female patient, right? What does it reveal? The menstrual history reveals heavy bleeding lasting 7 days every month. Like this, it is for 8 months. So there is chronic blood loss from the patient. So in this chronic blood loss, in this heavy blood loss, there will be iron also lost from the body. So when the iron is lost from the body, the hemoglobin synthesis will be defective. If the hemoglobin synthesis is defective, obviously MCV and MCH also decreases, leading to iron deficiency anemia. So this is the physiological condition. I mean the physiological basis. So what is the physiological basis? It is due to the chronic menstrual blood loss. Okay, due to this chronic menstrual blood loss, there is iron lost from the body, leading to iron deficiency anemia. Okay, so now the third question: what complications can occur if untreated? Okay, so what are the other complications which occur if this condition remains untreated? We all know that the RBCs supply oxygen, right? If these RBCs are only less, so the oxygen carrying capacity of the blood decreases, so there will be hypoxic condition. So that the perfusion capacity of the tissue, the perfusion of oxygen to tissues decreases, so hypoxia can be manifested. And even in severe cases, cardiac failure is also manifested if it remains untreated. Okay, and obviously the other symptoms of iron deficiency anemia like glossitis and angular stomatitis can also be manifested. So if untreated, it may lead to hypoxia, in severe cases cardiac failure, and other symptoms like glossitis and angular stomatitis. Okay, I hope you are clear with the first question. Now let us look at the second question. Let us read. A 40-year-old female patient presents with palpitations, shortness of breath, weakness, tingling and numbness of hands. On examination, she appeared pale with heart rate of 110 beats per minute, and her lab report shows hemoglobin of 8.2 mg per dl and MCV of 120 micrometer cube. Now, what is your probable diagnosis? Give justification. Next, give physiological basis of all clinical features mentioned in this condition. Define and classify anemias. Okay. Now, first we'll be looking at the symptoms. What does the symptom suggest? These are all the common symptoms: palpitation, shortness, weakness. But tingling and numbness of hands is a neurological symptom. When if a neurological symptom appears in the question, go blindly for megaloblastic anemia due to vitamin B12 deficiency. Okay, the neurological manifestations are manifested only in the megaloblastic anemia due to deficiency of vitamin B12. In any other anemia, these neurological symptoms are not seen. Okay, so this is what is the diagnosis? It is the megaloblastic anemia. Megaloblastic anemia. Now, give justification. So what can we give justification? First is the neurological symptoms. The first one is the neurological symptoms. And what might be the other one? We can see here the MCV is increased, right? MCV is 120 micrometer cube. So we can say that the MCV is increased, leading to large erythrocytes. Okay, so this is the justification. So it is the megaloblastic anemia because of what? Because of the neurological symptoms, and MCV is increased in the question. Okay, now give the physiological basis of all the symptoms in this clinical condition. Okay, now what symptoms are seen in here? Like, we'll go symptom by symptom. The first one is pallor, right? First, we'll talk about pallor. Why pallor is manifested in anemia basically? So we can see in the question that the value of hemoglobin is decreased, right? So if the hemoglobin is decreased, obviously the color of RBC is also decreased, right? So if the color of RBC is decreased, obviously the color of blood is also somewhat decreased, right? So the person appears paler. Okay. And what is the reason for palpitations? You can see in the question they have mentioned about heart rate. See, in the question they have mentioned about heart rate here. The heart rate is 110 beats per minute. What does this heart rate indicate? It is 110 beats per minute. It indicates tachycardia, right? And even in question they have mentioned about palpitations also. So this tachycardia along with palpitations is occurred in megaloblastic anemia. Why it is occurred? It is occurred as the compensatory mechanism. Basically what happens in this megaloblastic anemia is the O2 carrying capacity of the blood decreases, obviously leading to hypoxia. And this hypoxia, it stimulates the sympathetic activity. Sympathetic activity. Hypoxia, it stimulates the sympathetic activity, and the sympathetic activity leads to the increased heart rate and increased cardiac output. So if the heart rate is increased, obviously tachycardia and palpitations are seen. So this is the physiological basis of what? Palpitations. Okay, so we can write about the pallor. Why pallor is manifested? Because of the decreased hemoglobin. And why the palpitations and tachycardia is seen? Because of the hypoxia. Hypoxia stimulates the parasympathetic activity, leading to increased heart rate and increased cardiac output. Okay, now what might be the reason for weakness? The reason for weakness remains the same, because of the decreased O2 carrying capacity. And what is the reason of high MCV? MCV is very high. It is 120 micrometer cube. It is a very high value of MCV. Why this much heavy value of MCV is manifested? We all know that we all know we have all diagnosed the condition. It is the megaloblastic anemia due to vitamin B12 deficiency, right? In vitamin B12 deficiency, we all know that vitamin B12 is required for DNA synthesis, right? And if vitamin B12 is absent, DNA synthesis do not take place properly. Due to this erythrocytes do not divide and remain immature and large. So this is also one of the clinical feature. Okay, the answer for the second one, like it is also one of the clinical features. So we have discussed about pallor, tachycardia palpitations, and MCV, and even we have talked about the weakness. We have talked about MCV also. Okay, now the third one, define and classify anemias. I have made a separate video on this topic. I'll just put the link in the description box. If you have not visited, please do check it out. Now let us read the third question. Just a second. Okay, third question. A 52-year-old man underwent total gastrectomy of carcinoma of stomach. 6 months later, he presented with weakness, pallor, tingling sensation in his fingers. His peripheral smear shows macrocytic RBCs and hypersegmented neutrophils. Explain the physiological mechanism leading to anemia after gastrectomy. Describe the role of intrinsic factor and vitamin B12 in erythropoiesis. Mention the characteristic hematological findings in post-gastrectomy anemia. How will you treat this condition? Okay, I think you might have been diagnosed till now because of the tingling sensation in his fingers. It is megaloblastic anemia. Okay, we all know that it is a characteristic feature of megaloblastic anemia due to deficiency of vitamin B12. But the most important thing here is why anemia occurred. Why anemia occurred after gastrectomy in this particular patient. Okay, what happens in gastrectomy is they remove a part of stomach, right? So when they cut, the gastric mucosa damages, right? The mucosa of the stomach gets damages. Due to this damage, the cells here, the parietal cells which are present here, also get damaged. The parietal cells, just imagine that these are parietal cells. So when we take a cut, the parietal cells get damaged. Due to this damaging of parietal cells, there will be no secretion of intrinsic factor. If there is no secretion of intrinsic factor, obviously there will be no absorption of vitamin B12. If there is no absorption of vitamin B12, there will be megaloblastic anemia. Okay, I hope you are clear why anemia occurred after gastrectomy here. This is a reasoning question. There is a reasoning question here. Okay, CBME also proposed reasoning question for 3 marks in paper, right? So this can also be asked as a reasoning question. I'll just write here. Why anemia is seen after gastrectomy? Please ignore my handwriting, guys. So why anemia after gastrectomy? Because of this, when there is a surgical procedure happening at the region of stomach, there will be damaging of the gastric mucosa. When this gastric mucosa gets damaged, along with this, the parietal cells also get damaged. If the parietal cells are damaged, there will be no intrinsic factor. If there is no intrinsic factor, there will be no vitamin B12. And if there is no vitamin B12, obviously the erythrocytes are immature and they are macrocytic. Okay, we have all learned that in megaloblastic anemia we have macrocytic RBCs. Okay, so this is the physiological mechanism leading to anemia after gastrectomy. Okay, now describe the role of intrinsic factor and vitamin B12 in erythropoiesis. I have told you, for the absorption of vitamin B12 we require intrinsic factor. Okay, and for the synthesis of DNA we require vitamin B12. So for the synthesis of RBCs we require DNA, for it we require vitamin B12, and for the absorption we require intrinsic factor. Okay, so in erythropoiesis vitamin B12 intrinsic factor are necessary. I hope you are clear with this. I'll just repeat it again. For the erythropoiesis, for the normal erythropoiesis, vitamin B12 is required for the absorption. Vitamin B12 is required for the DNA synthesis, and for the absorption of vitamin B12, we require intrinsic factor. So, intrinsic factors along with vitamin B12 play a very major role in erythropoiesis, right? Next, the third question. Mention the characteristic hematological findings in post-gastrectomy anemia. What are the hematological findings? In the question only, they have mentioned that the RBCs are macrocytic. That is, the MCV will be increased. So that is one of the hematological finding. And when we talk about hematological findings in anemia, especially, erythropoietin levels are always elevated in any type of anemia. So erythropoietin levels are elevated except in anemia in which there is a chronic kidney disease. Except in anemias with kidney involvement, there will be increase in erythropoietin levels in blood in every type of anemia except in chronic kidney disease or anemia which is caused by the kidney problem. Okay, I hope you got my point. Erythropoietin levels are almost increased in every type of anemia except in chronic kidney disease. Okay, now what are the other hematological findings? Obviously, if there is a neurological manifestation, so it is the deficiency of vitamin B12. So obviously vitamin B12 will be decreased in the blood. That is also one of the hematological findings. So we have got the three hematological findings. One is about the MCV, it is increased, and the second one is the vitamin B12, they are decreased, and erythropoietin, it is increased. Now, how will you treat this condition? Please do comment. How will you treat this type of condition? We have discussed this in the theory class. The treatment is nothing but the intramuscular injections, IM injections of vitamin B12. So this is the simple treatment. Next, we'll move on to the fourth question. Okay, a 22-year-old student develops pancytopenia following prolonged use of chloramphenicol. Now, before entering into the question, I want to just introduce you to these two new terms. What is pancytopenia and what is chloramphenicol? Chloramphenicol is obviously a drug, as the by looking at the name we can tell it is a drug, right? But what is this pancytopenia? In the name we have pan. We all know now, pan India, pan movies. Pan means all, penia means decrease. So pancytopenia means decrease of all blood cells. So there will be decrease of all blood cells, that is decrease of RBC, decrease of WBC, decrease of platelets. This is called as pancytopenia. Okay. Prolonged use of chloramphenicol. Chloramphenicol is drug. It is antibiotic. It is used in very serious illnesses like meningitis. So chloramphenicol is a very strong antibiotic. Okay. Now let us look at the question. Explain the physiological mechanism behind aplastic anemia. What are the hematological findings? How is erythropoiesis affected in this case? This is a interesting question. Normally this type of questions are less asked in exam, but we will definitely have a look at them. Now first let us talk about the physiological mechanism behind this aplastic anemia. So first, what is aplastic anemia? It is the anemia caused due to the defective bone marrow. It is caused due to the defective bone marrow. Okay, if there is defective bone marrow, it leads to pancytopenia because all the hematopoietic stem cells are present in bone marrow itself. So if the bone marrow is only defective, the hematopoietic cells also get affected, leading to pancytopenia, that is decrease in RBCs, WBCs and platelets. Okay, now what does we have to do with chloramphenicol? This chloramphenicol is a very strong antibiotic. It causes the deposition of like it affects the bone marrow basically. So it affects the bone marrow, leading to pancytopenia. So this is the what can we what is this is the physiological mechanism. Okay, it is the physiological mechanism. It is nothing but the pancytopenia, which is caused due to defective bone marrow. Defective bone marrow, it is caused due to prolonged use of chloramphenicol. So chloramphenicol causes defective bone marrow. Defective bone marrow causes pancytopenia, leading to aplastic anemia. Okay, now what are hematological findings? We have discussed in the class of classification of anemia the hematological findings seen in aplastic anemia. I mean, the morphology of RBCs are normocytic and normochromic. So it is nothing but the MCV will be normal, MCH will also be normal, along with MCHC is also normal in aplastic anemia. Okay, now what are the other hematological findings? We have talked the erythropoietin is increased, and when we look at the bone marrow examination, more fat is deposited in bone marrow, and there are decreased hematopoietic stem cells in bone marrow. Okay, so what are the hematological findings? MCV, MCH, and MCHC are normal. There will be increased erythropoietin, and bone marrow examination reveals more fat and decreased hematopoietic stem cells. Now, how is erythropoiesis affected in this case? Obviously, bone marrow is affected. What can we write in this? The third question is erythropoiesis is affected due to deficiency of hematopoietic stem cells. Why hematopoietic stem cells are defective? Due to defective bone marrow. Why defective bone marrow? Due to chloramphenicol. And defective bone marrow is causes pancytopenia. Okay, I hope you are clear. If you have any doubts, any type of doubts, please do comment in the comment section. We learn together. Now, the fifth question. The fifth question goes like this. A 35-year-old woman presents with fatigue, sore tongue, a history of poor diet during pregnancy. Blood film shows macrocytic anemia without neurological sign. Obviously, macrocytic anemia without neurological sign, you have it in mind. Do comment, guys. It is obviously folic acid deficiency, right? It is due to the deficiency of folic acid. Now, what is the question? Explain the physiological role of folic acid in DNA synthesis and erythropoiesis. See, you will be learning this in detail in biochemistry, but I'll be just giving a brief to you. Okay, this folic acid, it is also known as vitamin B9. Okay, vitamin B9. This vitamin B9, it is converted to tetrahydrofolate and in the body, and this tetrahydrofolate, it what we say, it acts as carrier for the one carbon unit, one carbon atoms, or it carry it act the THF, the tetrahydrofolate, it acts as a carrier for the one carbon atoms. Now, to understand one carbon atoms, you will be learning it in more biochemistry. If I tell it here, the video will be prolonged, so I just don't want to prolong the video. So vitamin B9, it is converted to tetrahydrofolate, and this tetrahydrofolate, it is the carrier of one carbon atoms. Okay, now these one carbon atoms are necessary for the synthesis of DNA. Okay, for the synthesis of DNA, RNA, and proteins as well. Obviously, for the erythropoiesis, we require this DNA, right? So if there is no B9, there will be no conversion of to tetrahydrofolate, the THF, and there will be no carrier for the one carbon atoms, and there will be no synthesis of these nucleotides, and leading to defective erythropoiesis. I hope you got this point. If you have any doubts, please do comment. I'll clear it. Now, describe the hematological features seen in folic acid deficiency. We have discussed the hematological features in B12. We can write it here also, but we can change it, that there are decreased folic acid levels here. In place of vitamin B12, there is decreased folic acid levels here, and everything is same here. MCV is increased and erythropoietin is increased, but folic acid is decreased here. Now, How does folic acid deficiency anemia differ from vitamin B12 deficiency anemia? First is the neurological manifestations. The neurological manifestations are not seen in the folic acid deficiency anemia. And one more point we can write here is, in folic acid deficiency anemia, folic acid is decreased, and vitamin B12 deficiency anemia, vitamin B12 is decreased in the serum basically. And we can also write that the neurological manifestations, about the neurological manifestations, right? I will go to the sixth question. The sixth question is, a female aged 55 years come to a doctor with the complaint of intermittent soreness of tongue, periodic diarrhea, in addition to fatigue, breathlessness, anorexia, pins and needle sensation. On examination, the skin and mucous membrane are pale, the tongue is red and ulcerated, spleen is not palpable. Investigations: histamine, fast achlorohydria. RBC count is 1 million per mm cube. RBCs are irregular in size and shape. Occasionally nucleated RBCs are present in the peripheral blood, and thrombocytopenia. Now, what are the questions? What is the type of anemia? Obviously, we can look it by the question, looking at the question. Pins and needle sensation in the megaloblastic anemia, neurological manifestation. It is a megaloblastic anemia due to vitamin B12 deficiency, right? What is the most probable cause of anemia in this patient? By looking at the question, we can see the most probable cause might be. What do you think the most probable cause might be? Obviously, it is due to the autoimmune destruction of parietal cells, right? Vitamin B12 is decreased. That what does it mean? Intrinsic factor is not present for the absorption. Intrinsic factor is not present. There are no parietal cells. So it is due to the autoimmune destruction of the parietal cells. Okay, this is the most probable cause. What are the principles involved in the treatment of this patient? What are the principles? First is the vitamin B12 intramuscular injections along with the folic acid supplementation. So vitamin B12 is not given alone for an anemic patient. Along with vitamin B12, folic acid is also prescribed. Okay, so this is the principles of treatment. Okay, the vitamin B12 injections or the replacement therapy of vitamin B12 along with folic acid supplementation. And looking at the investigation, please don't be confused looking at this histamine first. Histamine, the first one, the histamine fast achlorohydria. Normally, when we inject histamine or when we infuse histamine in the patient, there will be release of HCl from our gastric cells. So achlorohydria means there is no release of HCl. Even after histamine test, there is fast achlorohydria. That is, there is no release of HCl. From this, we can confirm that the parietal cells are not present. So histamine test, fast achlorohydria means there is no release of HCl after the infusion of histamine, after the injecting histamine. Normally, after giving histamine to a person, there will be rapid release of HCl and gastric juices from our stomach mucosa. So after the histamine test also, there is no release of gastric acids. That is, what does it mean? It means achlorohydria. What does it mean? There are no parietal cells to release. What might be the reason for the parietal cells? It is due to the autoimmune destruction. So cause is due to the autoimmune destruction of parietal cells. I hope you got the question. Now the last question. We'll be reading the question. A 25-year-old farmer from a rural area presents with fatigue, pallor and pica. On examination, he is found to have anglostomatitis and cholionicia. His stool examination reveals ova of ankylostoma duodenale. Ankylostoma duodenale, it is nothing but hookworm. Okay, explain the physiological mechanism of anemia in hookworm infestation. So what happens in this hookworm infestation is, what does this hookworm do actually? This the Ankylostoma duodenale, the hookworm, it attaches to the intestinal mucosa. It attaches to the intestinal mucosa and sucks blood from the capillaries. It feeds on our blood. It sucks the blood from our capillaries. So each worm causes a chronic blood loss. So suppose there is if think this as the intestine, think this as hookworm. So if it infests on the intestine, so there will be formation of so intestine may cause perforations, right? Hookworm goes and attaches to the intestines, there is a chance of perforation because it feeds on blood. So there is a chance of damage of the intestine leading to perforations. So in hookworm infestation there will be chronic blood loss, okay, due to perforations. Why perforations? Because this sucks the intestine. It holds the intestine firmly, leading to the formation and leading to the formation of holes and damage to the intestinal area, and leading to perforation and leading to blood loss. So this persistent blood loss, there is loss of iron. Okay, if there is loss of iron, it leads to iron deficiency anemia. So in hookworm infestations, iron deficiency anemia is seen. Why? Due to chronic blood loss. Describe the changes in RBC morphology. We all know that it is the microcytic hypochromic, that is the MCV is decreased along with MCH and MCHC, right? Now mention the compensatory responses of the body to maintain oxygen delivery in this condition and suggest supportive treatment in this case. Okay, now this is an interesting question. The question number C, what might be the compensatory responses? Please pay attention. Compensatory responses in iron deficiency anemia due to hookworm infestation. So first, there will be increased cardiac output. It is one of the compensatory mechanism. Why cardiac output is increased? It is due to maintain tissue perfusion, to maintain normal tissue perfusion. Cardiac output is increased, and there will be increased respiratory rate. Why there is increased respiratory rate? For the more uptake of oxygen. For the more uptake of oxygen, there is increased respiratory rate. And what is another compensatory mechanism? There will be increased 2,3 BPG. What is this 2,3 BPG? So there will be increased 2,3 bisphosphoglycerate. You'll be reading again this about bisphosphoglycerate in biochemistry. Okay, this 2,3 BPG is also increased, and this 2,3 BPG, it shifts the oxygen hemoglobin dissociation curve to right. Okay, it shifts the curve to right. When the curve shifts to right, it facilitates the O2 supply. Facilitates the O2 supply. Simply remember, if 2,3 BPG is increased, the curve shifts to right. If the curve shifts to right, there will be more facilitation of oxygen to the tissues. So even the 2,3 BPG levels are also increased along with the increased erythropoietin levels. Okay, so these are the compensatory mechanism: increased cardiac output, increased respiratory rate, increased 2,3 BPG, and increased erythropoietin. And what is the treatment? What is the treatment? First, as it is the case of hookworm infestation, we'll be performing deworming. Just remember this, what is the tablet for deworming, because I was asked in the viva what is the tablet of deworming. I have answered the question, what is the treatment. I have told the examiner that deworming can be done, and he asked me what is the tablet. So I was blank at that time, so I want to share it with you. After my viva I have referred, so I'll be sharing. So it's albendazole. Have an idea, albendazole 400 mg. Albendazole 400 mg can be prescribed for deworming. Okay, and along with iron supplementation. The iron was lost from body now because of hookworm. So iron supplementation along with other nutritional support. Nutritional support means iron rich foods, increased iron rich foods. Okay, so this is the clinical case discussion in anemia. Hope it is helpful for you. If you have any type of doubts, please do comment in the comment section, and thank you for watching and see you. Bye.